I'm excited to have the opportunity to be able to present to you on chronic pain. I hope to be able to impart for you not only a better understanding of what chronic pain is, but I hope that I can equip you to be able to better care for these challenging patients. First, let's just take a moment to reflect. A little time to be holy. Remind us that the word holy doesn't mean goody-goody. It means set apart for sacred use. Because of that, I have to consider when my quiet moments are. And as I focus my mind and my heart on God, He then is transforming me, recreating me into the one God's designed me to be. Because of that, I commit to set aside blocks of time for communion with God. Before we are done with this presentation, these are the things I want you to go back and reflect on and say, did I understand all of these objectives? By the time we finished, you should be able to explain why you need to learn about chronic pain. You definitely need to describe the differences between acute and chronic pain. In order to explain those differences, you have to take it a step farther. I want you to be able to describe the neuroplastic changes that occur with chronic pain, and be sure to break that down. Break it down into both the central neuroplastic changes and peripheral neuroplastic changes. Review that fear-avoidance model. Be able to take a partner and explain to them, what does that fear-avoidance model mean? There'll also be appropriate screening tools. I want you to take time to print those off, read them, practice them, be familiar with them before you use them on a patient. We'll be learning different effective interventions that are presented in the literature, and then wind up at the end, and you'll need to practice so that you can actually perform a mock session of the Therapeutic Neuroscience education. For this scenario of the chronic pain patients, just take some time on your own to watch this YouTube video, and then I want you to reflect. Try to come up with at least 3 things these patients recommended to their practitioner. So what are some things we know about chronic low back pain? Well, Walls and Melzack reported in 2005 that 1 in 4 individuals will report persistent pain. It doesn't seem like a very large number until you consider the next bullet. Estimated cost for these individuals is $635 billion per year. That's a lot, and that was quoted in 2011. Overall, physical therapists have noted repeatedly in several studies they struggle in being able to treat these chronic low back pain patients. In the study with Latimer and et al., they noticed that one of the things PTs reported is they just felt they hadn't been trained well enough. Hopefully this presentation will provide you with some of that training. Before you can understand chronic pain, we have to go back to the beginning. I first want to start with basic pain perception as it was understood with the Descartes model in 1664. Descartes pointed out that the individual, when the foot was placed close to the fire, that extreme heat with the fire would activate the pain receptors. Then the signal would ascend up to the brain, and therefore pain was perceived. You can see how the modern medical model, that's called the biomedical model, is still very much connected to this old Descartes pain perception model. The biomedical model makes an assumption there's a direct link between the amount of tissue damage and the amount of pain perceived, and that all pain is caused by injury, and therefore any increased pain means there must be more damage. There's also a clear point that says that pain is either physical or psychological, and that chronic pain means that tissues are not healing and that damage is ongoing. In addition, nociception, or that perception of pain, and pain itself are synonymous. and that pain's an input-driven system that was seen as the individual puts their foot toward the fire, as that input of the fire would start the pain. And then the nervous system is like the electric wire as the signal would travel up to the brain. When considering the use of a biomedical model, it only provides three options to treat pain. That first option, the individual can take their foot out of their fire. Well, we see that when a patient either avoids movement, they display fear avoidance behaviors, or they pull back. They're taking the foot out of the fire. Or, second option, we can put the fire out. In modern day analogy, we give them pain medications or spinal injections. In fact, Melzack et al. 2009 showed there has been a 629% increase in Medicare expenditures for epidural steroid injections. In addition, that same study showed there was a 423% increase in expenditures for opiates for low back pain in Medicare patients. Just to put this in context, do you realize that your brain can produce opiates at 50 times greater ability than even the single injection? Just keep that in mind with that statistic. The third option to treat pain with this model is to cut the wire. Our modern day analogy is surgery. 20% of lumbar discectomy patients have the same or worse pain after surgery. And lumbar fusions in general, they only have a 50% success rate in improvement in their pain and disability. When considering the biomedical model, you only have one proposed course of action that can occur. With a biomedical model, as my symptoms increase in intensity, therefore it is believed that my pathology is also increasing in advancing and becoming worse. So therefore, I need to introduce an intervention in order to be able to turn things around. The observation of real-life patients shows us that this direct correlation between symptoms and pathology actually does not occur. In fact, as you can see on the left side, it's been shown that a patient can continue to report symptoms even though both the physical and diagnostic signs show complete recovery from the physical injury itself. Conversely, look on the right side. You've got healthy patients who show no symptoms at all, and yet I can clearly demonstrate significant tissue pathology, and yet they're reporting very little pain. How do we explain this? That's where the biopsychosocial pain model comes in replacement from the Descartes biomedical model. What are the two key differences with the model that you notice as you observe it? Take a look for a moment and discuss. You may note two major differences. One, now that individual is taken into consideration not just the noxious stimulus from the fire, but now it's physical, psychological, and social aspects that you can see that's impacting it. And even more importantly, it's now a bi-directional modulatory control. Notice the green descending control from the brain as well as the red ascending signal from the fire. So you have bidirectional modulatory control going on, and now it's a multi-dimensional experience that it can include the physical, psychological, and social aspects. Generally, when an individual is asked to define acute versus chronic pain, it's most commonly just given in a time frame. For example, Acute pain is pain less than 3 months or less than 6 months. Those tend to be the most common two that are used. That chronic means pain present past 3 months or past 6 months. But I would encourage you to take it a step further. Acute pain has three main aspects to it. It's adaptive. Okay, it's given to us for a purpose. It's there to help us change and fit into the environment in different conditions. It's transient. It will be present for a time, but it will eventually go away. It has a protective role to warn us of actual or potential damage by that noxious stimuli. Overall, acute pain is absolutely an unpleasant experience. Then if you compare that to chronic pain, let me introduce three terms that need to be discussed. Chronic pain is now maladaptive. It no longer provides meaningful or defensive purpose. It also persists even after the physical injury has healed. And thirdly, chronic pain now shows evidence of neuroplasticity, actual changes of the neurological system both centrally and peripherally, and we'll be discussing that more as we go forward. Overall, chronic pain for individuals becomes not just an unpleasant experience, it becomes life-altering experience. First of all, let's discuss the central neuroplasticity. What you have here is an fMRI picture of a brain. The top one is a healthy individual, and the bottom is a chronic pain individual. You'll notice that there are fewer areas that are lit up and active in the chronic pain patient. We do know there's differences here. Be careful not to read too much into this yet. We're still not completely understanding the new findings just yet. We do know that when you take several snapshots of a chronic pain individual, that there are certain areas that are lit up 24/7 and very seldom change or diminish. In addition, centrally, they have seen an atrophy of the gray matter. Again, there's just observations that have been made. We don't have a lot of explanation as to what's going on just yet. On the peripheral side, let's talk a little bit about two terms that you'll need to become familiar with. That is hyperalgesia and allodynia. Those are both things that actually all of us experience after an injury. So for example, if you have a bruise on your forearm, you know at that precise moment that it occurs, you have pain just at the area in which the injury occurred. But within a short period of time, the pain response will then take on a larger area around the bruise, okay? That is represented as the hyperalgesia. It's an increased pain response, pain perceived to be more intense than is actually necessary as related to the tissue injury itself. Allodynia refers to the fact that the pain is due to a stimulus that does not normally provoke pain. So on the graph there, you're seeing that a stimulus had to occur to a certain intensity level before it could be perceived as pain. Well, under normal circumstances, that would not be perceived, but then when hyperalgesia has been present for a long period of time, then lower levels or stimulus are required before that person actually perceives pain. So in proposing the switch from a biomedical to a biopsychosocial pain model, we have some things to ask ourselves. Is this particular model just for certain patients? Or does it apply to everybody? If it does apply to everybody, how does this alter my evaluation? And how does this alter my treatment? These are questions you need to reflect on and see what answer you have. In an article by Burton et al. In Spine in 1999, they had some suggestions of some education modifications that would need to be done to help those clinicians switch from being driven by that biomedical model to being able to embrace the biopsychosocial model. So, for example, when they initially did concepts of spine anatomy, injury, and damage with a low back pain patient, it's now being suggested that be careful, that really you want to point out to this individual that there really is no sign of serious disease or suggestion of permanent damage. Previously, the spine was described as weak and that they needed to avoid activity when in pain, where now it's being suggested that the patient needs to know the spine is strong, and pain does not mean that your pain has serious damage. Previously, patients were encouraged to be passive in their role, in which they were dependent on someone else to tell them what to do. Versus biopsychosocial, you want to encourage positive attitudes and enable that patient to be able to cope on their own. Biomedical model was driven that the individual, if they were still having pain, that meant therefore they needed more intervention, in fact, often surgery. Biopsychosocial model states that numerous treatments are available, but relief depends on the effort of the patient itself. Again, moving them out of that passive role, giving them power, empowering them. Biomedical model concentrated on pain and not activity. Biopsychosocial, it shifts you to say, nope, now we're going to focus on activity, restore normal function for our patients. Being educated and knowledgeable about chronic pain will help you in being able to take care of your most primal patient expectations. Pretty much across the board universally, when patients come to you, these are the 4 things they want to know. They want to know what is wrong with me. They want to know how long will it take to get me better. They also want to know what they can do for themselves as well as what you can do for them. Take into consideration these questions as we proceed forward and talk to you about treatments that have been shown to be effective for low back pain patients. Research has also shown that cognitions and brain are correlated. Basically, what a patient thinks, what they feel, and what they believe about their condition, it will significantly impact the examination, the treatment, and the prognosis. Even more importantly, they found that fear, anxiety, and pain catastrophization were strongly related to pain and disability. So if I had a patient that was very fearful, very anxious, and doing some catastrophizing, that patient had very high levels of pain and disability. In fact, Arnst and Peter in 1995, they made a statement that has been quoted over and over again throughout the research literature for chronic low back pain patients, and that is, the fear of pain is worse than pain itself. Therefore, what we as clinicians need to remember is, what is that patient fearful of? That's where the success will come, when I can determine what is their item or movement that is threatening them and causing them this fear and anxiety. The fear-avoidance model has been presented in research many times and has evolved. Here's one of the more advanced models, and let me help explain it to you. Let's begin in the center of the picture where it starts at 5A, where the individual first sustains an injury itself. Every one of us will then have a unique pain experience that is multidimensional. It is physical, psychological, and social. Each and every one of us, it will be different. Now, depending how much fear is involved in that pain experience will then determine which way that individual goes on that continuum. Relatively low levels of fear, most definitely absence of fear, will take them toward the right side of the slide, and they will be able to confront their pain and therefore recover. But those individuals who have higher levels of fear, and anxiety, particularly those individuals who then do pain catastrophizing. These are those patients that say things like, if I bend over, my disc is going to blow out of my back. I'll never stand up again. I can't lift anymore. And even while they're saying these very dramatic things, sometimes their face will appear almost unemotional. That's known as negative affectiveness, where they don't appear to be very emotional even though they're saying these very dramatic things. These individuals are experiencing pain-related fear. They will then choose to avoid activities such as bending over to pick something up or coming to therapy or going to work. Because of that, it's like a self-fulfilling prophecy. Now we're at the top of that circle at disuse, depression, and disability. Now those issues compound their pain experience, increase and fulfill that whole concerns of fear and anxiety, and they're stuck on this merry-go-round of this fear avoidance model. In order to get them off this model, we have to be able to directly address the things that are feeding it, and that is the fear, anxiety, and catastrophizing that the patient's experiencing. When that person begins to catastrophize, do realize it is becoming irrational. They cannot be reasoned with. I need to get them to a safe environment for them to recover and find their way back, and therefore it's very important to reserve judgment during this time. One of the useful outcome measures that has been found to help assist you in determining where your patient is with their level of fear and anxiety is the Fear-avoidance belief questionnaire. It's a 16-item questionnaire specifically designed for low back pain patients to measure their fear and avoidance beliefs. It's been found to be both reliable and valid. There are two sections to it, and they found that the fear avoidance belief questionnaire for the physical activity section greater than 14, or the fear avoidance belief questionnaire work section if it was greater than 34, those two scores have been associated with higher levels of disability and work loss. So for example, if I test this individual and they're found to be at greater than 14 on their physical activity section or 34 in their work section, I would then be very concerned about their disability and work loss potential. They recommend that even if you're unable to get a fear avoidance belief questionnaire to use at that moment with your patient, that it's actually quite accurate to just simply ask these simple questions. 1, what are you afraid of? Are you afraid the pain will get worse? Are you afraid therapy will increase your pain? Overall, Maitland in 1986 was able to show that a skilled, thorough, subjective exam needs to include listening for my patient's fears. In the next 2 slides, there will be a patient scenario that we will review together. As you're reviewing it, this is what I'd like you to do. What would you highlight would be potential yellow flags for this patient? What additional information would be helpful to know about this patient? And list 3 possible interventions for this patient. So let's go over the scenario together. Your patient's name is Susie. She's 38 years old. She had 3 years of spinal pain complaints. Most recently, she was diagnosed with fibromyalgia. She's seen numerous healthcare providers with the most recent treatment of epidural steroid injections, radio frequency denervation, and home stabilization exercises. She notes good days and bad days with her pain, but more bad than good. She reports pain across her low back, which radiates into her legs. She states that the pain has a mind of its own. Stress increases her pain. She notes disrupted sleep. She stopped cooking as she can only tolerate standing for 15 minutes, and sitting is limited to 60 minutes in a car. She also stopped her part-time job as an office manager. Additionally, her general health is good. She doesn't have any specific joint problems. She does have a family history of low back pain. Her physical findings, her trunk motion was limited to flexion and extension of 10 degrees due to pain. The rest of her motion was within normal limits. Her straight leg raise was sensitive at 45 degrees. The left was equal to the right. Her slump test, her leg pain was produced with neck flexion motion. And on palpation, she was tender at L1 through L5. She was tender over the SI joints and the PSIS. And she was tender in her bilateral hips. And she was unable to perform a transverse abdominis or a multifidi contraction. Well, let's see how you did. Well, some of the yellow flags are that Susie has seen numerous healthcare providers. That generally tells you something's going on there that needs to be looked into more closely. Her comment that pain has a mind of its own was a yellow flag. Her stress increasing her pain is a yellow flag, showing a connection to her social environment. In addition, her stopping her working her part-time job was a yellow flag too. What would be helpful to know? Well, having an outcome measure, particularly the Fear-avoidance belief questionnaire, or you could also use the pain anxiety symptom scale 20, which is your shortened version for the patient. That would give us a more accurate idea of if she's got fear avoidance or pain catastrophizing going on. What would be 3 possible interventions? Well, the literature is going to show us, as we'll discuss coming up, aerobic exercise. She might possibly need graded activity depending on her FABQ score. She definitely needs some therapeutic neuroscience education, and this will be explained later in the presentation. So what kind of literature evidence is there for these chronic low back pain patients? Overall, these 4 things have consistently shown effectiveness in the literature. The first is cognitive behavioral therapy. Next is graded activity, aerobic exercise, and then therapeutic neuroscience education. Cognitive behavioral therapy, the major goal was to replace maladaptive patient coping skills, cognitions, emotions, and behaviors with more adaptive ones. Research literature demonstrates effectiveness for the past 40 plus years. Overall, though, literature does show that the cognitive behavioral therapy misses an exercise component. In addition, overall, there tends to be poor medical reimbursement and also poor patient compliance for this type of treatment. Another option seen in the literature is called graded activity protocol. This was first described as being operant conditioning, in which if I reward the well behaviors of this patient and ignore their pain behaviors, I then will encourage the well behaviors to occur. So exercise and physical activity were basically found to be incompatible with the pain behavior. Therefore, graded activity was a way to stimulate the exercise behavior in order to lead to a decrease in the competing pain behavior. A common description of graded activity protocol consisted of 16 sessions, of 1-hour sessions 2 times a week for 8 weeks. The components of each of those 1-hour sessions included a warm-up, core stabilization, lower extremity strengthening, either an activity of daily living or a work simulation activity that was found to be a fearful activity for that patient, and then the final element was aerobic conditioning. So the first 3 sessions, the participants performed each of the exercises in all those component areas previously described. Each exercise, though, they only did to their individual limits of pain. So, for example, if you gave them a lower extremity strengthening exercise of hip abduction with a Therapeutic, generally patients do about 10 repetitions. But what you would do is you would set the patient up. You would say, yes, the average is 10, but I only want you to do as many as you would like to do. And then you recorded how much they did. It was also important to watch them and give them appropriate feedback. You had to be careful the patient did not overdo as well. So you watch for any loss of posture or grimacing, etc., and you caution the patient to stop at that point. Then those 3 sessions, you recorded how much the patient could do for each exercise. Then you added those together and took the average. So example again, back to the hip abduction with a Therapeutic exercise. Let's say the first day they only did 5. The next day they did 6. The third day they did 7. Therefore, your average would be 6 for that. Once you average those 3 visits and establish the individual's baseline, then the therapist and the patient sat down to determine what would be the final goal that would need to be achieved at the end of the 16 sessions. Once they agreed upon that ultimate goal, then they took that exercise and divided it by the remaining amount of visits that would be still need to be done, and they would have a quota. So for example, with the hip abduction exercise with a Therapeutic, you might start with a red band for 10 repetitions, but your ultimate goal would be at the black band for 2 sets of 10. Therefore, in those next several sessions, you would slowly increase from red band to green band to blue band to black band, etc. And you would mark down each visit what each exercise quota was to be. Once this was done, the patient needed to agree that they would complete all of the exercises despite their pain complaint. This is a big difference. Remember, the first 3 sessions, they were allowed to stop whenever they wanted to. Now you have shown them that we found the safe limit for you. Now we're going to slowly expose your body to a little bit more exercise each time. Even though this might very well increase your pain, you are assuring them each time that they are still safe. It's important that while the patient's in graded activity, that you refrain from the use of any passive modality in the clinic. This is so important to empower the patient to be active, and any passive modality like ultrasound could reinforce for the individual that they have actual tissue injury, which is what you're trying to discourage them from focusing on. You're trying them to realize that there is not tissue injury and that the pain is actually something that can be replaced with the exercise activity. It is okay to educate the patient in the independent use of heat or ice at home because this is still very empowering and they're able to do it on their own. The physical therapist can use manual therapy techniques in conjunction with the graded activity protocol, as those have been found to do 2 things. 1, they do improve the relationship between the patient and the therapist and improve the trust. And 2, it does help the individual perform the exercises with less discomfort. The most important thing is that at each and every session is that this educational message is repeated over and over again, letting the patient know that yes, they have pain and the pain does hurt, but this does not mean that it's harmful to you. That exercise and physical activity that I've given you are recommended and safe despite your pain symptoms. And even more importantly, I am here each and every day to assure you that you don't go too far or harm yourself. I'm here to watch you. My primary goal is to improve your function, not your pain relief. Now, that educational message I just shared with you is the information that was there before these recent new neuroscience discoveries. Now, with the new neuroscience discoveries, we can say to the patient that graded activity does directly address your pain relief, where primarily before it was just about improving function. Now we know that the exercise we have them doing will address this pain relief, and we'll explain that to you more specifically as we start to describe some of the specific changes that occur neuroplastically. These next several slides are to introduce you to the concept of therapeutic neuroscience education. This information is gleaned from a book called Therapeutic Neuroscience Education, Teaching Patients About Pain, A Guide for Clinicians by Adrian Lowe and Emilio Puentedura. First, I have a question for you. When part of your body is injured, special pain receptors convey the pain message to your brain. Is this true or false? Write this down before we get to the next slide. So, did you answer true or false? Well, let me give you an example before I answer it for you. This young woman here is going to step off the curve. As she's about to step off the curve, she oversteps a little bit and she turns her ankle inversion and immediately sprains her ankle, tearing some ligament tissue. At the same time that she turns the ankle and the tissue is tearing, she looks up and she sees this large truck coming at her. So, do you think she feels any pain? Actually, the answer would be no, not at that moment. But that takes us back to the first question. Do we have special pain receptors that convey the message of pain to our brain? The answer is false. Okay? Even though she sprained her ankle and she had actual tissue injury, therefore you would assume that she would feel the pain. But her brain is the one that makes that decision, not the pain receptors. And in this particular case, the danger or the threat of the truck coming at her and possibly killing her is so strong and so much more important that she is then able to, again, here's that bidirectional modulatory control. She's able to send a signal back down to those injured tissues to actually inhibit that pain from that injured tissue at that moment. The important takeaway from that is that injury does not always equal pain. Injury does not always equal pain. In fact, let me share some more research with you. Approximately 40% of non-symptomatic people have a bulging disc on an MRI. So if I went to a basketball game and I offered free MRIs, just basically telling you, and all the people assured me they don't have any pain at all, I would still find bulging disc on 40% of those people. Lumbar spine degeneration begins actually in your early 20s. And overall, they have found very little correlation between the amount of arthritic change that occurs that you can see on imaging and the level of an individual's spinal pain. Also, over the age of 70, 2 out of 3 individuals have been found to have an asymptomatic, so no pain whatsoever, rotator cuff tear. 35% of collegiate basketball players with no knee pain whatsoever will actually show significant abnormalities on their MRI. So all of these individuals show potential significant symptoms that should be causing them pain, but no pain is registered. How about those of you who are runners or those who have young children? I know I've been running for miles. Didn't feel a thing until I get all done and realize, my goodness, look at my toes. I've got a blister and sometimes bruising going on. Never even noticed it at the moment. Or your kids when they come in from playing and their legs will be full of bruises. They don't even remember what they did. Remember again from the fear-avoidance model that each and every one of us has a unique pain experience, and it's a multi-dimensional experience. The most significant part of that is what level of fear do we have associated with that particular injury. The key overall to whether a patient is going to experience that pain is, do they perceive what is experiencing them to them a threat? So when you get a chance, go back and review that patient scenario of Susie and look at that again and say, what does she feel threatened by? Be specific, because the more specific you are and the better you are in identifying what is that level of threat, the more effective you will be in being able to intervene appropriately for treatment choices for your patient. Second question. Nerves have to connect to a body part to the brain in order for that part to be in pain. So, my nerve of this individual's hamstring needs to attach to a certain specific spot in his brain in order for there to be pain. Is that true or false? Well, the answer to that question is false. The most dramatic example to that is phantom limb pain. We know that these individuals are experiencing significant pain, and yet there's nothing that can possibly connect to their brain because there's no body part anymore. It also is important to point out another piece of information they've found. Remember back to your somatosensory cortex as pictured in the slide here. And each of the areas represents a different part of the body. Your foot, the hip, the trunk, the arm, the face, etc. Well, in this particular case, let's take into consideration this individual's low back. One of the things that they found is that individuals who are in pain for a long period of time, they actually were able to see that the representation of this low back pain patient who's been in pain for a long time, that representation on the somatosensory cortex has actually become less distinct. Not more clear, but less distinct. And as it becomes less distinct and less recognizable by the brain, the interesting thing is that the individual's pain perception actually increased. It did not decrease. That is seen better in the example in the next slide. In a study by Stavrono Della Penna et al. In 2007, they had an individual place one of their healthy arms in a sling. They then were able to note that the image of that arm was less distinct on that individual's somatosensory cortex in as little as 30 minutes of immobilization. They also noted that the patient then had increased perception of pain to that very immobilized arm. So, studies by Mosley, Zaluki et al., they then showed that chronic pain patients were also shown to have these distorted images, which was then correlated to their increased pain perception levels. Mosley described this as disruption of laterality. So, for example, what he noted is that those individuals who had this distortion of their images, if I then showed them pictures of an individual with a low back turned either to the right or to the left, and if they had to quickly identify the picture if the individual was turned right or left, they had difficulty identifying that. And that over time, working with them on their improvement of their laterality then did bring down their overall pain perception and improved the distinctness of the representation of their back in the somatosensory cortex. Okay, so how are you doing so far on your true false? Another question. In chronic pain, the central nervous system becomes more sensitive to danger signals from tissues. Is this true or false? The answer to that question is true, and it's called central sensitization. And let's look into the specifics of what they've been able to identify thus far. With persistent firing of the C fibers, it was noted that the interneuron may die due to the high levels of amino acids. With the loss of this interneuron, the individual then has decreased ability to modulate their nociception. So one of the things with central sensitization is noted, central sensitization is that the loss of interneurons occurs with the persistent firing of C fibers. Another central sensitization neuroplastic change that is occurring is related to the action potential windup. When there's repeated stimulation of that C fiber, it can elicit a progressive increase in the number of action potentials generated by that motor neuron and interneurons. So the second change found with central sensitization is action potential windup. The third evidence noted with central sensitization was that there was a reduction in the endogenous chemicals being released that would provide the descending modulation. Without the production of these chemicals, this individual was unable to modulate their pain perception. Therefore, it allowed more information to the brain and it could result in an increased pain perception overall. Some of the endogenous chemicals could include the opioids, enkephalins, endorphins, and serotonin. Can you remember the three pieces of evidence that showed there was central sensitization occurring? Did you remember that it was number 1, death of interneurons, number 2, action potential windup, number 3, reduction in endogenous chemicals that provide the descending modulation? Can you guess what this picture represents? Give it some thought. What do you think? This picture demonstrates that there is also sensitization occurring in the peripheral nerves. So just as there were changes to result in central sensitization, there are several things occurring for peripheral sensitization. And the key to those changes is those things that improve synapse function. So when an injury occurs, for example, let's take someone who is bending over to take their luggage out of their back trunk, and as they do that, they strain the muscles and hurt their low back when lifting that luggage out. Well, one of the evidence has shown that in addition to the muscles being torn, the peripheral nerves are also traumatized, and that myelin of that nerve can be damaged by the mechanical force of the injury, or myelin can be injured through immune processes or chemical processes. And when there is the loss of that myelin on that peripheral nerve, then the nerves adapt by immediately making more ion channels in that area in which the myelin's lost. In addition to making more ion channels, it can even change the distribution of those ion channels. For example, let's say it was an injury that caused a lot of emotional stress. Well, some of your ion channels are actually activated by stress. And the more stressful the injury and the more stress that occurs afterwards, then the body will actually adapt by creating more ion channels that are opened as a result of that stress. In addition, It's also been shown that the ion channels can stay open longer. These three things, the increase in number of the ion channels, the changing of the distribution of the ion channels, and making ion channels stay open longer, are all three things that can strengthen a synapse of those peripheral nerves and therefore lead to peripheral sensitization. One thing that's important to talk about, since I've been emphasizing over and over again, the central and peripheral sensitization. Please be clear that neuroplasticity is something that can be reversed. So even though these changes are occurring as a result of the chronic pain that has occurred, they can be reversed back to the normal levels again. In fact, just to point out with ion channels are replaced every 48 hours. So interventions can turn these patients around and reverse these neuroplastic changes. Injuries that occur in high stress environments, such as this very dramatic train accident where the car is lifted up in the air, have been shown to produce 7 to 8 times higher chance that that individual will have chronic pain. Other potentially high stress environments might be a job the individual hates, or maybe the injury occurred while they were being robbed as a crime was being committed. Just as we described previously, as we transition from a biomedical model to a biopsychosocial model, it's also encouraged that we go back and take a look at just what we define pain as. The classic description of pain as described in Mirsky and Bodak in 1994 states that pain is an unpleasant sensory and emotional experience which follows actual or potential tissue damage or is described in terms of such damage. With the unfolding of new evidence in understanding the neuroscience behind pain, we actually are being encouraged by such researchers as Lorimer Moseley to consider a new understanding of pain to the point of even defining it differently. Lorimer Moseley suggests that pain should be described this way, that pain is produced by the brain after a person's neural signature has been activated and concluded the body is in danger and action is required. I want you to reflect back and take some time reading the old definition and the new definition and see how understanding that the pain is truly produced by the brain, not by the receptors, not by the tissue injury, can really revolutionize how we address pain when we do encounter it. One of the most dramatic changes is being able to wrap our head around this statement that injury does not always equal pain. That can be a statement that can really be perplexing because as a clinician I say, but how do I accurately rule out tissue injury? Well, remember back to these foundational things. Do you know the typical healing times for tissue? Yes, you do. And if I know that and that time has passed, I can probably safely conclude that most likely it's not tissue injury perpetuating this pain. Did I take a good history to determine what kind of pain is this individual having? Did I do a fear-avoidance belief questionnaire or a pain anxiety symptom scale to assess the psychological social contributors? And did I learn about any potential underlying pathological causes? When I take all of those into consideration, I'm going to be more accurate in being able to describe who is the main contributor to this individual's persistent pain. Since injury does not necessarily equal pain, the key I need to look at in all of my patients is what kind of threat are they experiencing? When I can embrace this piece of information, I hope this will help you, all of you, to be less judgmental when you encounter those patients who are reporting pain that does not correspond with their physical findings. Instead of just dismissing them and saying it's all in their head, they're just being symptom magnifiers. Instead, I accept the challenge and I say, okay, there isn't a tissue injury, but if this person's experiencing this level of persistent pain, therefore I need to dig deeper. I need to discover what their threat is. And when I can identify that, then I can teach the patient how to confront the threat rather than retreating into disuse, disability, and depression, which will perpetuate that chronic pain cycle. Another tool that was introduced by Adrian Lowe and Emilio Puentedura was the Therapeutic Neuroscience Education. It was a process to educate patients about their pain. The first published study using that neuroscience education was actually conducted by Dr. Lorimer Moseley in 2002. One study demonstrated that those individuals with chronic musculoskeletal pain disorders, they showed a positive effect on pain, disability, catastrophizing, and physical performance after they were educated on the pain neurophysiology and the neurobiology. Moseley demonstrated in 2003 that one-on-one education showed more favorable outcome than group sessions. Therapeutic neuroscience education is a relatively new concept, and as yet, they don't have it completely spelled out. Overall, some of the things they feel should be a part of the content of therapeutic neuroscience education were placed on this list. They do feel you should talk about neurophysiology of pain, that you really need to avoid and be careful and cautious with the use of anatomical or pathoanatomical models. You actually should not spend a lot of time discussing emotional or behavioral aspects of their pain. They do suggest that you discuss and teach about nociception and nociception pathways. You teach about neurons, synapses, action potentials, help them understand spinal inhibition and facilitation. They need to understand peripheral sensitization as well as the central sensitization and the basic concept of neuroplasticity. The studies utilizing therapeutic neuroscience education have ranged from sessions of 30 minutes up to 8 hours of therapeutic neuroscience education, with the average being listed as 2.5 to 4 hours total. The suggestion for billing is to place it under neuromuscular reeducation. And then actually, it's strongly suggested that you actually educate the individuals while performing exercise or manual therapy rather than just sitting down in a one-on-one education. They also strongly suggest the use of colorful pictures with each session of the TNE. So even if you become an expert at this and you read all the literature there is and you become the best person doing TNE, I will warn you right now. You will basically get 3 responses. You will get, no way, this is not happening, I'm not buying it. You will get others who will say, I get it, but, and then they'll have several questions. And then you will have a few, thank goodness, who say, yes, I get it. So overall, seeking patient buy-in with this is still very challenging. Next, I will be providing actual examples of how to do therapeutic neuroscience education for your patients. Everything I've done previously contained very specific scientific terminology that's correct for other medical individuals, but not appropriate for patients. So I'll provide some examples starting with how to teach your patient about nerves. Remember that this therapeutic neuroscience education with your patients can be done while you're doing manual therapy or even exercise. For example, I often did soft tissue or strain counterstraining with my patients, and I would just begin the neuroscience education while I was working on them at the time. You don't necessarily have to sit down formally face to face with your patient. So first example, teaching your patient about nerves. I would start first by just telling my patient they have over 400 individual nerves that travel throughout their body, connecting all those body parts together. There's an estimate of over 45 miles of those neurons, and all of these neurons have electrical activity in them at some time. I will point them toward the graph, showing them the level of electrical activity that begins on the graph. Nerves communicate many factors to the brain, such as stress, movement, or temperature. And when those things occur, they then set off an alarm. And I show them the picture of the alarm. This happens when the electrical activity reaches the threshold level and produces an action potential. I again would redirect them to the graph, show them how the electrical activity increases up to threshold, and then the production of the action potential itself. So what if you step on a nail? Do you want your nervous system to tell your brain about this? Well, when you step on the nail, the nerves on your foot will light up like this Christmas tree. Once the message is received, though, and therefore the threat is passed, eventually the lights on the tree will begin to go down and eventually go off completely until they're needed the next time. Note that each of these examples are not something you have to do all of them with your patient, and you certainly don't do them all in one visit. It really is a matter of what did I find out with the specific history of my patient and what do I feel they need to hear first. This next example would be to explain how persistent pain is related to nerve sensitivity. I would mention to the patient, as we talked about how our nerves act like an alarm system, we talked how that electrical activity must reach the threshold before an action potential is generated to send information to the brain. We know that the system will quiet down again and return to its original resting level. Well, for every 1 in 4 people, the nerve activity does not return to normal, and it remains higher at an extra sensitive level, and I can show them the change in that threshold level. Prior to this episode, for example, you could sit to drive for 2 hours. Now you drive only 5 minutes and you feel pain. It's not that anything's wrong. It's just that your nerves have now become more sensitive. What kind of things can cause your nerves to be extra sensitive? Family issues, fear, failed treatments, job concerns, different medical opinions. You can see by this example how you can customize these comments depending on your patient's history and examination findings. This next is an example of how to explain how persistent pain is related to nerve sensitivity. So one of the things a patient wants to know is, how can I calm down my nerves? Well, I share with the patient that the pain produces potent pain medicine or happy chemicals. And these chemicals have a calming effect on our nerves. And those factors that maintain the excitement in my nerves also dries up these brain's happy chemicals. Good news, aerobic exercise can improve the blood flow and oxygen that the brain needs to produce these happy chemicals. This means a brisk walk, a swim, or a bike ride that allows you to break a sweat will then help the brain to produce those happy chemicals. Your medicine that you take can also calm down your nerves. So it's important to take your medications as recommended rather than waiting for the pain to occur before taking them. If you do that, then you are just chasing the pain, and it makes it difficult to bring that sensitivity level back down. Here's an example of how nerves can become extra sensitive to non-traditional stimuli. Your alarm system is more complicated than you may have realized. Sometimes your nerves become sensitive to other things, such as cold or stress. So when you go outside and it's very, very cold, and you suddenly notice that your pain has increased, you are not imagining things. Because inside your nerves, there's many different kinds of sensors. The example continues on this page. Each of these sensors respond to different factors. Some respond to temperature, stress, movements that we do, our immunity, are we healthy or well, or our blood flow. Now, when temperature changes, it does more than communicate that it's cold or hot. Now your pain increases as well. Good news, your sensors change every 2 to 3 days. So, if you have not increased pain with above, you can calmly, if you do experience, increased pain with cold, for example, you can calmly respond to your brain. It is just cold and that nothing else is wrong, and it is just a sensitization of my nerve, and you can then direct your brain to help calm down that signal. Remember, the overexcitement of these sensors just means increased sensitivity, not new pain. This next example explains how pain in other areas is more a result of spreading sensitization. So, if an alarm goes off at your house, your neighbors will want to know what's going on. Your nervous system is the same. These nosy neighbor nerves will wake up. They will cause aches and pains in adjacent areas, and it seems as though the pain is spreading. When the police cars arrive to investigate the alarm, the neighbors become even more nosy. Again, the nerve does the same, and the pain appears to spread even farther. Again, this is just sensitization and not a sign of spreading injury. This next example explains the use it or lose it phenomena. Have you ever considered why amputees have phantom limb pain? This question is important in understanding your pain. Scientists have measured brain activity while stimulating various body parts. What resulted is a somatosensory map seen above. Close your eyes. Touch your nose. The map in your head allows you to know where your nose is without your vision. When you're healthy, each body part is very clear and distinct on this brain map. If you don't move a part regularly, like if you injure your low back and you stop moving and you stay very guarded with everything that you do, then the more out of focus that low back image becomes on your brain and the more pain is present. This can be reversed by gently moving that body part and understanding that some pain may still be present, but it's not causing further harm. The key to recovery is regular movement. I will provide one more example for my patients, and it'll explain understanding central sensitization. If you would like more examples of how to explain this information to your patient, please refer to the book by Adrian Lowe and Amelia Puentedura. For this example, I want to tell my patient that at the top floor of this building is the CEO of a large company. He receives monthly reports from each department. And these reports filter through the channels of manager to department head to vice president before it gets to the CEO. Now, when there's a problem, the CEO often requests reports on a more frequent basis and even will insist that the information gets sent directly to him. Your brain can work the same way. Each part of the body will send regular information up the system to the brain. When problems occur, the signals to the brain increase in frequency and intensity, and now the pain occurs more often and appears more intense. This is not a reflection of the extent of injury, but rather an increase in central sensitization. So this brings us to the end of the presentation. At this time, let's look at the objectives again. Can you say why you as a physical therapist need to learn about this? Do you know the differences between acute and chronic pain? Can you describe the neuroplastic changes that occur with chronic pain and make sure you separate them, what occurs centrally and what occurs peripherally? Get out that fear-avoidance model. Can you talk your way through it? Can you explain what's going on with each of those steps? What were the screening tools that I presented? And make sure you spend time getting familiar with these forms, even having someone just pretend fill them out for you so you can score them and get used to the questions. Are you now aware of what effective interventions have presented in literature? Do you remember which ones I talked about? And lastly, go through those patient examples I gave you. Get a partner. Practice those mock sessions. Put your own words in there. Create your own pictures. Maybe even better yet, take it a step farther. Do some manual treatment on your patient while you're teaching them, or exercise with them as you're explaining to them about those nerves. I hope you've enjoyed your time learning about chronic pain. Thank you very much.